Thank you for choosing to come to our workshop. I've been asked to give you a reminder that at the back of your packs there's an evaluation form. If you wouldn't mind filling that in and then handing that in on your way out, that would be really helpful to the organisers to understand how they can improve anything subsequently and indeed what's gone well today. So that would be really great. Thank you. My workshop is, as Ros said, about informatics. And my name is Anne Cooper. I hold a role at NHS England currently as Clinical Informatics Advisor. But actually, I'm a nurse first. I just happen to work in a space that's called informatics. And I was quite intrigued by the conversations this morning about the family of nursing and how I got the impression that there was a tendency for us to work in tribes, for us to identify ourselves by a particular aspect of what we do, and then to not see ourselves as a bigger family. And informatics is a little bit like that too. So I'm a nurse first and I'm part of the big nursing family, and I happen to occupy a leadership position in informatics. First of all, I'd like to tell you a little bit about me and how that journey started, because I'm not really that technical. Indeed, I'm not really that good with numbers and so on. But I actually started to get an interest in how some of this stuff could be about nursing back in 1999 when I went to work at NHS Direct. And that group of nurses that you can see on that screen, this is in 1999. I don't know whether you can remember back then, some of you won't be able to, it's that long ago. But NHS Direct was in its very infancy, and we were one of the very first sites to go live, and that photograph was taken as a press shot to advertise in our locality that NHS Direct was going live. And Ros Moore, who's been talking today, was part of the team who worked on that particular project, as I was, as you can see there, and Ros appointed me, so that's how I know Ros. And that group of nurses, we were sat in a room with some technical people who kept on coming into the room and telling us about all of this stuff, about how things worked. And NHS Direct is an incredibly technical environment, and the other nurses sort of moved away and didn't really understand the conversation, and I sort of got it. And I started to see how it was actually important, and that somebody needed to stay in the room to actually talk about this to the technical people, because if we didn't stay in the room, then we were going to get something that we didn't expect perhaps, or indeed something that we didn't want. So for me, one of my ambitions around leadership for informatics is about encouraging nurses to engage in difficult conversations that are about things that are not always that easy to understand. And I guess one of the things that impresses me most about learning disability nurses, like Jane, who's going to speak after me, is your incredible ability to translate the complex into the simple. And those are the sorts of skills that are very, very apparent that you need in a technical environment too. You need to be able to distill out the very essence of what it's about, and then have conversations that change the nature of what's going to happen. And I guess that for me is one of the things I've learned about what you all do. So that was 1999, and since then I've done lots and lots of different things in informatics, and I guess I've had to earn my stripes. In the technical world, you're working with very clever people who expect you to understand certain things. So I did some studying and so on, but that's not what actually drives things for me. This is my definition of informatics, and this is my definition. It's not a textbook definition. And I think if you look on there, you'll start to see that it's actually about something that we should all be thinking about, which is about information. And when I did my studying around informatics, there's an area of informatics called consumer health informatics, and you all definitely know something about this, because that's how users of service, patients as I would call them, I've got a general nursing qualification, actually access information about what's happening to them, what their choices are and what their options are. So information is all of those different forms. It's not just information that sits in information systems. It's about information that you share with patients to help them to understand. It's about how you measure what you do, and that's one of the things that Jane's going to talk about. So my argument about informatics is it's everybody's business. Every single one of you who sit in this room are doing informatics every single day. It's just you don't label it that way. And I think that's my ambition, is to make it clear to everybody that we are all informaticians. And it can be translated into every setting. So this is just illustrative. Roz was very clear to tell me when she left a few minutes ago that the Compassion in Practice strategy for England doesn't apply across all the countries, but I'm using it here as an example. So, you know, arguably, if you look at that document, you won't see anything in there that says informatics. But actually, if you look at the things that need to happen as a result of that strategy, informatics is everywhere. So in the first one that's about care, in there is something about people having the right tools to do their job. And in some instances, those tools are technical tools. And if you look at the one that's got measurement in its action area 5, if you're going to measure things, you've got to have the ability to collect information to benchmark things against. Informatics is woven through practically every strategy that I've ever seen in one guise or another. So what do I think it means for nursing and midwifery? I think it's all of those things on that screen, and I think one of the problems with all of this and the informatics agenda is that trying to draw you all into understanding that it's part of all of our business is quite difficult when it's all going so fast. Everything is going so fast. We know that the population's expectations around how we use technology, information, the tools that we've got to our work far exceeds where we really are. We know that patients and service users are increasingly, or their families indeed, are getting more and more access to information. And if you talk to the doctors, they talk to me regularly about when they go into consultations, people actually are walking in with printed out sheets of information before they actually start the consultation. And indeed, some of the evidence shows that patients are actually checking their own diagnosis with the GP rather than going in for a diagnosis. And that's a different form of power base to where we've been for a long, long time in nursing. Information navigation is a set of skills that I'm trying to encourage people to think about, and you guys know about this. So how do we know where the best resources are for our populations? How do we judge something to decide whether or not it's high quality or not? How do we understand whether something's giving good evidence or bad evidence, and that we can share that with users? And I think these are skills that we haven't openly talked about before. Certainly in England, and I suspect it's happening elsewhere too, the issue around transparency and the need to be more visible in terms of our performance is a big agenda for us, and that requires us to be able to look at information. Clinical safety is a high thing on my agenda around, if you look at apps are a really good example. So when you go into I've got an iPhone, if you go into the Apple Store and look at all of the apps there that are about clinical stuff, in inverted commas, how do you make a judgment about what's right or wrong? How do you know that those calculations that are embedded within that app are giving you the right answer or not? And I have some real concerns about how we embrace safety in that new space. Clinical content's really important too, and I think when you're all recording information in record systems and so on, that's what I call clinical content. I wrote a blog about it fairly recently. And I think we underestimate the impact of clinical documentation in its first instance, but also when we transfer that into electronic settings. And the second picture is something that was done by the RCN, which is if we don't document, and I think Jane will be starting to explore this in more detail with you, if we don't document what we do, then we are effectively invisible. Our contribution to the care of populations is effectively invisible. But this is the backdrop. This is a real challenge. One of the things about technology in particular, rather than specifically information, is that sometimes it makes things worse before it makes things better. And we have to grapple with making sure that the technology that we adopt actually helps rather than hinders what we do. And a lot of these things are taken from the recent press around how systems are actually getting in the way, how bureaucracy of recording information manually even is starting to actually impact adversely on what we do. And certainly that's work that I've been getting more and more involved in. But technology can do the same thing, interestingly enough. Putting technology in doesn't necessarily make it better unless you do it really well. So I ran a leadership program a little while ago, and we had some learning disability nurses on some of the groups that I ran, and one of the things that frustrated the hell out of it for me was that they were really struggling with imposed systems that were designed to do something else. So quite often say they would be in a mental health trust where they were coping with a system that was really never designed to do the tools, tasks and things that they needed to do. And technology is much cleverer than that, so we need to be more energetic about asking for what we need to do the work that we need to do. So these are the things that are the challenge for us, I think. Certainly technology can help us with a lot of these things. So I think, again, information weaves through all of these things. Technology can help people to stay independent. If you look at some of the telecare and some of the telehealth stuff that's going on, it can do that. It can help people to have a more positive experience of their care, and it can help them to express their experiences back to us. We can measure impact. We need more leadership in informatics. I can't carry on being the person who holds the baton. I need more people like you guys to get it. And we can use technology to support positive staff experience. You know, if we've got I'm using hospitals because it's the example that I know best, because that's where I do some clinical practice. The matrons wander around with clipboards, manually recording things, and then have to go to a back office to input it into spreadsheets. We just can't, that's not a positive, that's not why those people go to work every day. We need to use technology to enable some change in that space. And that's me, and I'm going to hand over to Jane, who's going to, I think, hopefully link what I've been saying into more learning disability related work. Is that right, Jane? The lights here are weird, by the way. And we've got some time for questions at the end, because she might want to argue with me. Do you want this, Jane?
Okay, they are weird, aren't they? Right, I'm Jane Smith. I'm a learning disability nurse and have been a learning disability nurse for nearly 30 years now, which is showing my age in terms of the bar chart this morning. I'm a general manager of a learning disability service up in Yorkshire, and the service I manage covers children through to adults, and it covers services that are deployed out to local authority communities, and also some very specialist health services that we directly manage and provide, including some inpatient beds. The reason I suppose I'm here today talking about informatics is because I had the opportunity last year to work with the clinical team in the informatics department at Department of Health alongside Anne, looking at the clinical leadership agenda for learning disability nursing and informatics. And what I found in that year was, you know, there are massive questions, there are massive opportunities, and there's a load of work we need to do. And what I wanted to do this afternoon is really just to build on some of the themes that Anne's talked about and share my thoughts on, you know, what I think some of the key challenges for us are, and also share some of my own experiences in terms of the services that I work in and work alongside, and the reality of some of that. So, okay, making information understandable is what we do. We've heard this morning lots and lots of examples of what learning disability nurses do and what learning disability nurses do best. You know, the NMC, learning disability nurses use innovative ways to communicate with people. We do it, we've been doing it for 30 years. I've been doing it for 30 years. People have been doing it, you know, a lot longer than that before me. You know. And we know that if information is understandable, that supports people to make informed decisions. You know, we heard that from a very legislative perspective in terms of the Mental Capacity Act, you know, and some of the work that was done in research. Principles are all the same. So the question that I want to pose this afternoon is, what about actually in our practice? Do we provide and require information that's understandable and allows us and others to make informed decisions about our services? We know what we do for service users, and we know we do that well. But what about our actual services? And I want to think about, information is everywhere, but I specifically want to just think about it in terms of two areas really, population information and performance and service information. do we know who the population with learning disabilities are? I think we do, but do we? The organisation I work in has recently merged with other trusts and become a much bigger organisation. And we're doing a piece of work around transforming learning disability services. And as part of that, we brought all the services into a room to talk about what the learning disability pathway would be. And I suggested that actually the first question we needed to ask was, are we all talking about the same people? When we're talking as a trust about the pathways for people with learning disabilities, do we mean the same people? My colleagues, I think, sort of gave me airtime and allowed me to ask what they thought was a crazy question. But the reality was we weren't. You know, our child and adolescent mental health services, who had recently joined the trust, had a slightly different population that they saw in their learning disability services to what the adult learning disability services saw. So actually, when we were looking at what goes wrong with transition, we had two problems. We had a transition pathway we needed to improve, and we also had a transition pathway which was the wrong pathway anyway, because those particular individuals in that group needed to be transitioning to a different part of the adult services, not ours. So it sounds like a simple question, but do we really know the answer? Do we talk the same language as our partners? We all work in, you know, whether we work in the NHS, the independent sector, local authorities, you know, we all work within organisational definitions. Are we clear that the organisations that we work in use the same definitions? Do we ever have that conversation? You know, and do we talk the same language as each other? There's recently been a piece of work which many of you might be aware of, where commissioners have been required on the back of some of the Winterbourne actions to produce information about the amount of people in their areas with challenging behaviour. I work with four local authorities and 6 CCGs. I know that each one of those has used a slightly different definition when they've drawn up their list, and I think that's true across the board. So how do we use what we know to get the maximum benefit? We do have lots of information about our population. We gather lots of information, but do we actually use it to get the maximum benefit for them in health? And I think this is another question, you know, that I'd like to think about. Annual health checks have been around for a number of years now. They're common currency. They're very much part of the day job, hopefully, in most of our areas. And those health checks give us a lot of information about that health of that individual. But how many of us are using that information to tell us anything about the populations? I came across a service last year in the Midlands who'd actually taken the annual health checks model a step further and had started to draw some aggregate population data from that, which was actually enabled them to identify that in one area of their geographic patch there was a particular issue around obesity. In another area there was a particular issue about high numbers of the learning disability population that smoked. And what they have done is actually reallocate the resources within their community services, so they're specifically targeting the health needs that have been identified. Now, we've all got that information in our areas because we've all got service users that are having annual health checks. But when I talk to lots of areas around the country and lots of CCGs, actually we're not using that information to tell us anything or to help us to plan how we deliver services other than to the individual. You know, so are we missing opportunities? And secondly, I'd like to think about service and performance information. And I suppose just pose a few questions. Do you know what your organisation measures in your team? Wherever we work, whether we work in the NHS, independent sector, people gather information about us. And that information is gathered and it's taken somewhere and people look at it and they form opinions. And those opinions often translate into things like, you know, future commissioning, you know, where the cuts are going to be next year, you know, what teams are doing. But actually, do we really know what people measure? And if we know, does it tell the right story? Is that what we really want it to say? One of the things that's measured in the organisation I work with, and I know from talking to colleagues in quite a lot of organisations around Sequins, we're part of a large trust, mental health trust. Sequins were the Sequins and performance indicators were issued across the board, not specific to LD in our localities, and one of them was the safety thermometer and measurement of pressure sores. I really like the safety thermometer. I think as a methodology it's got a real benefits and real opportunities, and it's a really good framework for understanding what's happening in areas and being able to act and improve on that. But actually, for the population that we were measuring, it was irrelevant. You know, I've got 8 beds for challenging behaviour. Majority of our service users who come into our services are very healthy, fit, ambulant individuals. So month after month after month, my nursing staff were returning nil. All that achieved was that they think it's a waste of paperwork. We've missed 2 opportunities for me there. One is we could be measuring something useful that really tells the commissioners, you know, about the job we're doing, and the other thing is we're switching people off measuring anything, because if all you're doing is putting in a nil return about something that's not relevant, what's the point? I've challenged that this year, and we've got a set of sequin measures for our services that are absolutely specific to learning disabilities. You know, it's a new challenge because now we have to, now they really do matter, and we really do have to achieve them. But actually, we're starting to measure that quality, and it becomes meaningful. One thing I would say to you is if you've never seen the performance reports in your organisation, and they will exist in some form, go and have a look at them, ask to see them, and really think, you know, does that make sense? These are 2 charts, just examples really of things. The first was some performance related to sickness that went into our board. Team C, with 50% sickness, got a really big black mark, and people were sort of jumping up and down saying, I don't know what on earth's going on in that service over there. Actually, Team C has only got 2 people in it, and the performance reports are based on the percentage of people off sick in a team. Team A and Team B, which were working age adults and old people services teams, are sort of 40-50 people strong, you know. But it gives people form an opinion of a service, and if you don't know what's going in, you can't challenge it, so find out. The real irony of it was, you know, we knew that we had somebody going off sick, somebody going in for surgery and who was going to be off sick, so we'd actually seconded somebody into that team, so it didn't matter. The second one, which is sort of the reverse of that, is our bed occupancy target, which goes to board. Again, bed occupancy measure for our organisation. Commissioners like to see 80%, that's their sort of line. Working age adults and older people services are well over that. LD sort of well under. Actually, that's great. And if those, you know, from my perspective as the general manager of those services, the lower those columns are, the better, because our philosophy is to keep people out of hospital. We don't want people in beds, and we deploy our services and our staffing resources into the community to support people and just bring them into the bed bases to manage the people that need to be in when they need to be in. But until we actually had the conversation about this is meaningless, it's not telling you what you need to know. You need to be measuring something completely different. That was what was going. And until I started having those conversations, you know, there was this feeling, some of the board, they don't bother to come and ask you. They just decide LD are pretty crap. You know, why have we got an LD service? You know, so you need to know. You need to know what it says. Does it make sense? Ask the question. And when we collect data, it's about making it meaningful. It's about understanding what the question is, making sure we're answering in the same language. So if we're asking people to tell us the amount of people they have with challenging behaviour, who do we mean? Do we mean people in secure services, or are they forensic behaviours? You know, it sounds simple, but those are the conversations that are going on out there. Measure useful things. Don't measure things that aren't relevant to the service, because that just creates paperwork and tells you nothing. And then use the information. Some of you may be aware that we've got an LD census coming up in a week or so, on the 30th of September. There's been a lot of work gone on. I've noticed a really positive work gone on around actually preparing people for that census, and I hope making sure that we are going to be speaking the same language, we are going to be counting the same things, and that what we are measuring is useful. But one of the questions that was asked at the briefing session that I went to was, what do you want to know? You know, we're gathering all this data, what do you want to know? And I think we need to be responding to that as services, you know, asking the question, that if the data's out there, what does it tell us? You know, if we're submitting stuff, it's not going into a big black hole. Just wanted to show you this. Okay, thank you. And that last one was really to say, you know, it is about asking the question, and sometimes if we ask the right question, it makes an awful lot of difference, and we need to be thinking what those questions are, because the question's often more important than the answer. Thank you.
Maybe about what we've said. Has anybody got any questions they would like to ask us? No questions? I don't believe that for a second, okay?
Could you tell us a bit about what the learning disability specific sequence that you adopted?
We've got three. One was the implementation of an outcome measure. Unfortunately, it's not the HEF, because we'd actually started the conversations before the HEF came along, but I think it will be the HEF next year. The second one was about positive behaviour plans and levels of restraint, because we felt that was a really important thing to be measuring, and a really valuable thing. And the third one was trying to turn on its head a sequin that had been standard for a number of years, which was around patient experience. And in the past, the patient experience sequin had been, you know, we were required to do a questionnaire. Well, that was, I mean, we did it, but it was, it was a tick box exercise as far as I was concerned. So what's the third sequence is that we have committed to actually running a multimedia inclusive event for service users to gain feedback on some issues that we've agreed with the CCG. So those are the three that we've put in place this year. And it was really about, I think for me this year, it was really about getting, in the first instance, my organisation and the contracting department, part of my organisation, to support the fact that there was no point in measuring things that weren't useful and weren't meaningful, and we needed to get them to measure. Actually, it was much easier to convince the CCGs than it was to convince my organisation. So I think we've made a start.
Is anybody else collecting data?
That's question.
The link, obviously what Jane and I have been seeing directly links, I suspect, to what's going to follow us in terms of workshops. So I find that absolutely interesting. So I've been trying to talk about the generic. Jane's coming to, and I think you're going to talk more specifically about that. So is anybody else doing measurements around sequence? I'm quite interested in understanding whether that's a prevalent thing going on in the system or in Europe. Yeah?
Just to say there is a sequence ahead.
Right, okay, and that came after Jane started her earlier conversation.
Yeah, it's been published now, but
Yeah.
there's a sequence
Yeah.
ahead.
Yeah.
We have a sequence for the amount of community staff that had had learnability awareness training,
Right.
and we had a target of 1,000 people, and we had a similar one in the acute hospital. But what I'd be interested in as well is, because I've been supporting GPs for a long time now to do health checks, one of the barriers that we come up against is that they have this wealth of information on their systems that we can't access readily, and it would be really useful to know how many people in Norfolk have a learning disabilities or also have diabetes or asthma, because I think that's got service delivery implication to it, particularly with the kind of number of learning disability nurses and the way in which their work is directed. We're in a process of transformation with our teams at the moment, and there's sort of the thinking is that there'll be 4 sort of specialisms, if you like, within community teams, and I would argue there doesn't need to be 4. You could probably do 2 specialisms, because the need for kind of more health support is much greater than we know about.
Yeah.
But we don't know about it because I can't get that data.
Yeah.
Absolutely talking about what I call informatics around population. And
Yes.
you're absolutely right, a lot of that information is locked away in systems, and in the past we haven't been as forward, I think, in asking for access to that information. I can only speak for England because that's where I know best. There is a move to liberate some of that information in a safe way that protects people's identity and so on, to enable people to analyse population data, to enable us to better plan. So I feel quite confident that we're moving in the right direction, but I'm not absolutely sure that we've quite got there yet.
No, it's my own frustration. They do it, don't they? If I phoned up the central office, they'd be able to say that, I don't know, 6,000 women had mammograms last year.
Yeah.
But this is 6,000 women, that's not broken down into anything.
Yeah.
So if you were going to do it for the learning disability population, what you might do then is take 2%, but I know that's not accurate. And I'm really data phobic and very computer phobic as well. But having done this role now for a long while, I feel really strongly that we've got all this information, how useful it could be, and although sort of data isn't, my most favourite thing in the world, it's such a powerful tool, and it's really
Absolutely.
I mean, I feel abused that you're sitting there and
Yeah.
saying, wanted to add something. Yeah, go on. Excellent. Absolutely. That's brilliant.
Yeah.
That's a really good example. And I'm really enthused that it's practitioners who are, or people who have a clinical background who are asking for that and understand the power of that. That's why I think information is powerful and liberating on a number of levels. So those are really good examples. It'd be great to see this often in detail. So, any more questions, comments? Give us some of the...
I just want to ask something you were saying earlier about information that people are gathering that's not fit for purpose. So using a system that doesn't work for
Absolutely.
them.
Absolutely.
What is the point?
Jane and I are not, we say only collect what's meaningful. It's a mantra of mine, meaningful data collection. If you're asked to collect something and you don't know why you're collecting it, ask, why am I collecting this? How is this contributing to the care of my client population?
And I think the other bit for me is if you see information out there and it doesn't make sense, ask where it's come from. You know, one of the things that I've sort of been promoted quite a lot when I've been talking to people is the IHAL website and what is now becoming a really sort of growing and valuable amount of data on there. And I've had quite a few people said to me, yeah, but it's wrong. And I suppose my question back to them was, well, if it's wrong, how's it got there? Because it's not wrong. The IHAL data is what's in the system. So what are you putting in the system? And this is why I'm saying, it's about going back and sort of saying, actually, how are we reporting? How are they counting the number of people with autism, in our area? They've got a figure, we don't agree with it. Where's it come from? And it's really understanding what comes through and where people are getting information from, because
But sometimes people are not listening to that. I've said those sort of things to that website, and it's like, well, that is, there's very worthy people who've written books and these are the populations, and those figures don't actually, in reality, end up they're not the same. And so people have to sort of listen to people who are in the field as well doing that work.
but
I think sometimes the two need to come together, don't they? And you need certified measures, clinical outcomes, audit. They're all those that we're all very knowledgeable about you as nurses. And we've used for years. We've been data collecting since day dot. That's how the NHS is where it is. I think it's just terms, words, and probably how we gather that information that scares people away sometimes. I think the two coming together and finding a common ground that where they go, well, actually, yeah, I can do this, and it's not something that's foreign to me, and it's not something that scares me, or is actually going to challenge my position, my role, or the service as a whole, or stuff like that. So
I think it is quite scary though. I think unless we actually own this space, I honestly believe people will do it to us, and that's a scary thing to me. So my encouragement to you all is that we own this space, that you guys, there's Jane's gone back to her secondment. There's nobody who in my informatics space who is a specialist learning disability nurse, nor is there likely to be. And I do my best to advocate for you all, and Jane calls me now and again to do that. But at the end of the day, what I need is you guys to occupy the space. So when there's discussions about numbers and counting and informatics and technology, that you don't run away. Because my experience was 10 years ago, when all those nurses were in that room with me, they all pushed me to the front and all backed out of the room. And I think it's changing, but I don't think it's changing quickly. So that would be my challenge to you already. How are we going to occupy this space?
Can I answer that? Okay, no, it's just to say that it's very timely actually, because a piece of work that's going on at the moment is they're putting together the minimum data set for learning disabilities. Now, most of the people on that group are psychiatrists. Don't ask me why.
You know what you're saying?
Yeah, but because at the end of the day, it'll be nurses who collect this data.
absolutely.
But nurses really now need to say what they think would be,
How can they do that?
data.
Yeah, so
Well,
the
people can either write to me or the guy who at the Department of Health who's leading on it is called Zawa Patel. But if people want to write to me, I'm very happy then to pass on the details. But I would say get in there and
occupy your space.
yes, and my plea would be we do not want to use HONOS as the outcome measure, we want to use the HON.
Yep.
And so if people just wrote that in, but get engaged with it, because otherwise you will be collecting data that it will be meaningless